As much as I wanted, I did not garner additional conflicts since the last talk. So let's go through, in order to understand salvage of esophagectomy, we need to start understanding what is the rationale for the current treatment of esophageal cancer. Now, the way I pointed to my patients to make it really simple, and I find it true with any cancer that I deal with in the chest, is you either have metastatic disease, in which case I can palliate you and send you to an oncologist, no surgery usually. You have very early disease, in which case you're lucky and you can usually have surgery or some sort of a procedure to take care of you. Or where most of the people lie is you have intermediate disease, where we need to come up with some multi-modality therapy because it has the best chances of increasing the patient's survival. Now, so the questions in the 1980s that were addressed by clinical trials through the cooperative groups, and RTOG, as you all know, is the radiation therapy oncology group. The question was how to put things together in terms of therapy for cancer. And for esophageal cancer with either squamous or adenocarcinoma, the first question is, what's the benefit of combining chemotherapy and radiation therapy? So RTOG 85, and a secret, it took me 10 years to figure that out in the cooperative group, is the first two letters is the year in which the trial was approved. So that's a clue. So they looked at 129 patients with squamous and adeno and randomized them to chemoradiation versus radiation therapy alone. And in the radiation arm, there was 0% 5-year survival. In the chemoradiation, there was 26% 5-year survival. So that's the first signal that there is a benefit to combine multimodality therapy, and B, there is some long-term survival with chemoradiation alone. So now you have two streams. The surgeons trying to make the case that surgery is relevant, and the chemoradiotherapist trying to make the case that surgery may be relevant for some people, but not for 26% of the people.